Good afternoon and welcome to the Emergency Care Improvement Programme webinar series, covering a range of topics to support delivery of urgent and emergency care services across the health and social care system. Although designed to support the 28 ESIP systems, information contained within these webinars is relevant and open to all, so please feel free to share with colleagues. Today's webinar on working with voluntary and community sector will be delivered by Emma Bingham and Elizabeth Pyper from Age UK, Margaret Reynolds from the British Red Cross and Allison Smith from the Royal Voluntary Service. However, before we start, we just have a few simple housekeeping points. This session is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during this recording. At the end of the presentation, there will be the opportunity for you to ask questions. If you have any questions, please use the Raise Your Hand option on the panel on the right-hand side of your screen. Alternatively, you can write your question on the Questions section on the panel. During the question and answer sections, we will unmute you for you to ask your question in person, or if you do not have audio enabled, we will pose the question on your behalf. Thank you. And now I'll hand you over to the team for today's presentation.
Thank you very much for inviting us to present our webinar today. We're going to be talking about how working with the voluntary and community sector can help better achieve patient outcomes. Today we aim to highlight how collaboration with the voluntary and community sector can help the NHS to achieve objectives in emergency care. To explain how at each stage along the patient journey, the voluntary and community sector can help prevent short-term pressure points from building into future crises, and to demonstrate how engagement with the voluntary and community sector can lead to better outcomes for people, better service provision, and reduce cost and demand on the NHS. We have quite a lot of experience of working together and individually, helping individuals in the community. Age UK makes life-enhancing services and vital support available to people in later life, working nationally with a network of 164 local organisations, Age UKs, to deliver a range of services across the UK. The British Red Cross helps people in crisis, whoever and wherever they are. It is part of a global voluntary network responding to conflicts, natural disasters and individual emergencies, with over 30 years' experience in providing valuable, time-limited support to vulnerable people across the UK. The Royal Voluntary Service is one of the largest volunteer organisations in the country, focused on supporting older people through its 35,000 volunteers across Great Britain, working with 100,000 older people every month. Together, we support people in hospitals and in the community through on-ward support, home from hospital services, good neighbour schemes, and help support individuals to remain independent, safe and well at home. As I've said, we have lots of experience of working together. By combining our expertise and experience, we create flexible solutions. Our three organisations work together to provide a single point of contact, making it easier for health professionals to engage efficiently with voluntary and community sector providers. Examples of this include some of the services that we're currently running, which include Action Cambridge at Ipswich Hospital, which is around prevention of admission. Hospital to Home at St James's Hospital in Leeds helps support discharge. And the Dementia Care Ward at Kettering General Hospital supports dementia patients on medical wards. These are just a few of the examples. Margaret is now going to talk through the patient journey and how the voluntary and community sector can make a difference.
Thank you. So in this illustration, we describe the types of services that we provide to help along the patient journey. And we have two examples of our planned support services and our unplanned support services. So, for example, a planned service might be some of the work that we do with oncology services, where we would transport an individual to a planned appointment and take them to the appointment, wait for them at the appointment, and then bring them home, as well as working with GP surgeries, for example, with a social prescribing model. today we're going to focus mostly on the unplanned services and models that we have, looking at the front door, which is the A&E side of things, where we assist people home from A&E prior to discharge, and also with on-ward support, where we work with individuals in the hospital, for example, people with dementia, and also the back door, which is from the wards, where we become part of the discharge planning team. So looking at the front door, where we work with people who have been admitted to A&E, and our work here is very much around ensuring that people who don't need to be admitted to the ward and can go home, but possibly the hospital staff might have some concerns about that individual being vulnerable or maybe living on their own. So where there might be a lack of social support, we would assist, particularly where somebody, or only where somebody is medically fit to go home. We would assist with three components of the service, which is taking the individual home, resettling them when they're at home, and then following up for welfare checks. An example of where we would have this type of service is in Worcester, which is a rapid response assisted discharge service. So we would aim to see the individual, to see the patient and assist them home as soon as, but generally within an hour if possible. And what we find with this type of model is we work very much with the hospital staff and all the wraparound services, such as social workers, OTs, discharge teams, etc., with the key aim of promoting independence. And at that point where the individual is at home, we would be connecting in with other voluntary sector organisations to make sure that the patient who's been discharged home has every service that they need to remain in their home. So within this A&E assisted discharge type service, the models that we have, the impact that we make is that we ensure that the individual has a safe and supported return journey to their home. So we ensure that we have all of the medication collected prior to the individual being in the car. We assist with making sure there's keys. Once we get the individual in the car, we would then make sure that we do a complete check on everything that it is that they need in their life, a holistic check. And then once the individual is home, we make sure that we do our risk assessments. We check that there's milk and food in the fridge, and we can buy shopping, and sometimes we take shopping packs home with us from the hospital, and then we leave all our numbers to make sure that that person is supported and can call us at any time to reconnect the next day or as and when they might need us. We would also follow up with a welfare check at the next day, and where needed, we can then follow up with other services as well. What works for us very well with this type of service is where we have a nominated lead in the hospital to support what we're doing. And we also work very, very well with all of the hospital staff. And it tends to work really well when we have the staff involved in the referral procedures and looking at the types of information that we need from hospital staff, and also what, vice versa too. And making sure that we're available and flexible to be there at particular crunch times if there are particular times when the hospital is most busy. That works very well as well. So then looking at the on-ward type of support that we provide, our intention with this is to support the individual during their stay in the hospital. So for example, we have the dementia-friendly activity room at St. James's Hospital in Leeds. And we work with the patient, the family, the staff to support that individual. for example, with that particular service, we provide regular activity sessions and tailored one-to-one support to help the patient to feel more safe and secure on the ward, and to maybe minimize the amount of wandering that might take place, or to assist with you know, less falls happening. So we're there to support with that. It can also help with the reduction in the use of antipsychotic medication, and certainly it helps to increase patient and the family member satisfaction, as well as we've had so much feedback from hospital staff as well about the difference that our intervention can make. Some of the critical success factors in this type of service for us are the fact that our staff are trained, are highly trained and very skilled in terms of, for example, dementia and other conditions, and that it is our intention to communicate consistently with staff and to be that connector between staff, family and the patient when it's needed and if requested. And then looking at the back door, the supported discharge from the wards, again, this is quite a similar model to the A&E, where we would provide transport, settle the individual home, and also follow up with welfare checks. And with this, the type of people being discharged from the ward, we find that sometimes we need to remain involved for a bit longer, because perhaps after their hospital stay, they need that extra support at home to get back on their feet, or to be more independent, or to live the life that they wish. So we have in this example here, which is in East Lancashire, it's a two-tier service. So we specialize in most of our services in trying to create a one-stop shop for hospital staff, because we find that this is really key, that that hospital staff who know who to go to in our team, so that we can connect them with the all of the other wraparound services that we have in the voluntary and community services. And so the first tier here would be where we take the individual home and settle them into their house. And then the second tier being where we would then connect that individual with any other service that they might need in the community. So this works very well in terms of being part of multidisciplinary teams, and where we have services based in the hospital. It works very well that we're part of that whole process of discharge planning, and we can make sure that we know as much as possible about the patient prior to discharge, and then upon discharge can mobilize services really quickly to prevent them from being readmitted, and to promote a rapid return to independence. So by connecting the individual with services that we already work with in the community, and indeed our own internal services such as handyman, that type thing, we make sure that the individual is enabled to stay at home and is empowered to retain their independence and to connect with their community. So that's just an example of some of the types of services that we have. And in general, with most of our hospital services, having a really good rapport with the hospital staff and obviously the patients has been a really critical success factor for us. And to hear more about that, I'm going to hand you over to Allison.
Thank you, Margaret. Working with you, I wanted to highlight quickly what some of the expectations are that you can expect both with working with us, but also critically what we need from you as well to deliver a successful service. So as far as the expectations of what hospital staff can expect from us, we provide very much a specialised and professionalised service. Both amongst our staff and volunteers are very highly experienced and highly trained, whether it's around data protection, safeguarding, confidentiality, and health and safety. Also, critically, we can work very flexibly with you to support you to do your job hopefully better. I think this is very much highlighted by Sharon's quote here, which very much kind of illustrates the point that we're trying to make, that the services that we provide are very much about supporting you to deliver a quality service and very much taking some of the pressure off of frontline staff. Critically, what we need from you as far as how we deliver a successful service is very much being embedded in the patient journey, in the discharge pathway, and this very much involves being involved in critical meetings, whether it's bed flow meetings, discharge meetings, critically having a coherent referral process. Data sharing is also very critical at sort of key crunch points to enable us to react quite quickly to address patient flow issues. Critically, we need to be seen as an equal partner in this, helping you to deliver a first-class service. As far as what the voluntary and community sector offers, there's a range of support within the community, some of which has already been highlighted by Margaret. But I really just wanted to drive home three critical areas, or summarize three critical areas that we can help in. So one of the critical areas is very much improving access to community health services. So the three charities that are represented here today very much work in partnership locally. We can be a gateway and a brokerage to access smaller community services, but also more specialized condition-specific services which we can sign post clients to. Critically, a lot of our services are very much around preventing admissions, because we know that the research evidence is very clear about keeping people safe and well in their community. That's where people want to be. A lot of our services are very much around helping people to manage their conditions, whether it's around sort of referring to more specialist services, or if it's about any lifestyle changes that we can support them to do, such as increases in physical activity, but also through social activities and reducing isolation and loneliness. As Margaret has already pointed out, critically, a lot of the services we provide within hospitals is very much focused around discharge management. And critically here, it's all about helping people to transition from a period of crisis in hospital to at home and independence and being safe and well. I wanted to highlight some of the key differences we can make, and this very much aligns with possibly some of your concerns and certainly what's set out in the NHS Outcomes Framework. So we can help you to achieve the 4-hour target by ensuring timely discharge. We can also focus on reduction in preventable admissions and also length of stay. Improvement in turnaround time of emergency vehicles as a result of improved patient flow. Critically, we're really interested in preventing admissions, particularly within 30 days, and really helping people to transition from a state of perhaps dependence in hospital to a state of independence and well-being in the community. And critically, we're very much around improving the patient experience. So would want to help you achieve some of the improved scores as far as the friends and family test. This very much is around sort of highlighting some of the kind of the headline messages that you've heard through this presentation so far. So I just very much wanted to sort of summarize and recap. So critically, we are very much part of the solution as far as increased pressure and demand. We have a number of tried and tested models to reduce and prevent pressures on staff and hospitals, and working in partnership with voluntary and community sector organisations, whether it's our 3 charities or sort of other charities more local in the community or condition-specific charities, can lead to better outcomes for all. And lastly, I just wanted to flag up some of our contact details. Should you wish any further details or information on anything we've said, please contact one of us on the emails on this list. Thank you.
Thank you, ladies. That's it's a really interesting presentation. Now, has anybody got any questions about anything that you've heard this afternoon? Please raise your hand on the panel or write the question in the question and answer section. Well, we don't have any questions at the moment. Just to reiterate what I said earlier on, this has been recorded and will be uploaded to our web system. We will also be able to take any questions if you think of them after this presentation is finished. And if you'd like to email any questions to us, we can get those over to the ladies that have presented today. And that email address is ecipinfo@nhselect.org.uk. I'll repeat that. That's ecipinfo@nhselect.org.uk. We still don't have any questions, ladies, so I'd like to thank you very much for taking the time out of your day to give us this presentation. And goodbye from all of us, and thank you for joining the webinar.
Thank you.
Thank you.
Bye.
Bye.